keynote speaker, but she gave pediatric grand rounds downtown, and because of the change of venue last minute, it's a little bit of a drive from downtown. So to give her enough time to get here, we are going to have her talk next. And so in the meantime, I am going to be talking about imaging in the neonatal brain. Disclosure, I'm not a radiologist, but I do really enjoy looking at neuroimaging, and I think it's really important, especially in the neonatal, assessment, neurologic assessment. So again, I'm Margaret Means. I am one of the new child neurologists at Norton Children's, and the director of our neonatal neurology efforts. So very happy to be talking to you today. So we're going to briefly review neuroanatomy because I know that we have kind of a mixed audience, so harken back a little bit to med school. And then overview some of the most important imaging modalities, so head ultrasound, MRI, and CT. I'm going to talk about the indications and along with that the limitations of each modality, and then do some practice interpretation with case examples. And I apologize, I'm going to talk really fast because there's a lot to cover, and I get really excited, but I'm going to try to be speedy because we are short on time. So, review of neuroanatomy in like 2 minutes. So we have on the, let's see, is there a pointer or a, can you see my mouse? Kind of? Okay. So here we have our frontal lobe, parietal lobe, occipital lobe, and temporal lobe. Those are the main cortical lobes of the brain. And then if you look sagittally, you can see this is the corpus callosum, the big bundle of white matter fibers that connect the two hemispheres. Over here, we'll be talking about the ventricular system a lot in neonates and neonatal imaging. So you have your two lateral ventricles that are filled with cerebrospinal fluid. You have your intraventricular foramen of Monroe that drains that fluid into the third ventricle around here that's in between the basal ganglia of the thalami. And then your cerebral aqueduct that drains into the fourth ventricle. And so that is your flow of CSF. And here is a bird's eye view of that. So the basal ganglia are very important. They are kind of, well, the thalamus is kind of like the relay system. So those are these guys right here. Basically everything that comes, everything I think except olfaction, except for smell, that comes from the cortex travels through the thalamus down into the brainstem and the spinal cord. So it's a very important relay system for most things. And then the basal ganglia, the other deep gray structures of the brain, the caudate, the putamen, and the globus pallidus, are important kind of in general for, we think of usually motor movements, but also some behavioral changes as well. And then you have your cerebellum. So it used to be that we thought that the cerebellum was really just motor and coordination, but there's a lot more to it than that. And we've been finding that out like as more lesions are described in the cerebellum. It's very important in speech, language, and even emotion and emotional regulation. All right. So this is a busy slide, but I like to show it because I think that it gives a great overview of how much brain development is happening in the third trimester. And if you think about it, a lot of our preemie babies are spending their what would be the third trimester in the NICU, which is a very different environment than the uterus. So here on the right, you have MRI images. So these are T2 weighted images, and I'll talk more about those later. But so you can see this is about a 26-week gestational age baby, and these are all normal infants. So really the only sulci that you see are the central sulcus right here, and then the Sylvian fissure here, and otherwise the brain is smooth. And so, so I show this to say that gestational age is so incredibly important in interpreting imaging, because if this was a term baby, you would say, oh, they have lissencephaly or smooth brain. But it might be completely normal for a 26-weeker. And then just the amount of development that happens over just a matter of weeks. So up here, these triangles are cerebral volume. So the cerebral volume during the third trimester nearly doubles. And then your cortical surface area is what is really striking. So it nearly triples. And you look at just the degree of folding that happens at the later stages of, late preterm and term infants. So the degree of sulcation and gyration. Over here, it's just kind of a reiteration in a different form of, you basically have a smooth brain when you're a 24, 25 weeker, and then you gradually develop all of these very complex folds and brain structure. So take home message, it's really important to know how old the baby is, and if the imaging that you're getting matches that maturation. Apologize for the quality of this image, but it's one of my favorite books, and so I just took a picture of it because I think that so this is again a T2 MRI, and it's actually fetal imaging, so babies in the uterus, but it goes through all of the gestational ages again and in a coronal view, and I think in this coronal view you can really see the germinal matrix well. So this is this intense area right here in the caudothalamic groove. I'm going to be talking about it a lot because it's very important. So the caudothalamic groove this is the caudate, the head of the caudate nucleus, and this is the thalamus. So the germinal matrix lives right here, and it's basically the birthplace for most neurons and glial cells, a lot of the supporting cells. So from about 10 to 20 weeks, it is the birthplace of all of those cells, and then it continues to kind of produce cells, and then they will migrate out to where they're supposed to be. It's important because it reaches its maximum volume around 26 weeks, and it is very, very vascular, right? Because it is producing so many of the cells, and so this is the region where the interventricular hemorrhages that we see in preemie babies usually occur. Whenever you get swings in blood pressure or hemodynamic instability, you can get ischemia to that area, and then you reperfuse and get hemorrhage, or you can get hemorrhage just outright from high blood pressure, just because the vessels are so packed in there. That's really an area of kind of vulnerability. And then the reason that we get IVH in younger babies is because again, that max volume is around 26 weeks, and it continues to be there. Full involution is usually by about 36 weeks. We usually think more about like 32-ish weeker, like you really shouldn't get IVH after that, or, unless you're unstable. But in any case, so this I thought was a good view of that germinal matrix right there. And then myelination. So we talked about cortical differentiation and development, but then myelin is the other part, the major part of the of the brain development. So it is basically the fatty substance that wraps all of the axons of the nerves that communicate with each other. And we can see a really beautiful progression. I'll talk more about this when I talk about MRI, so I'm not going to spend too much time on it on this slide, but you can just see I'll just say the color change for now, right? So myelin on a T2 image is bright. So you really have minimal when you're a 31 weeker, maybe some brainstem. And then that progresses all the way to adulthood. So again, I'll talk about that a little later. All right, so let's get into head ultrasound, because this is probably the most frequent image that we get on babies, and for good reason. It's non-invasive, it's inexpensive, it's portable, you don't need sedation or radiation. They can come to the bedside and do it if a baby is unstable. The fontanelles are nice little windows that babies have into their brain, at least for the first few months of life. And so usually we do the anterior fontanelle, which is the big soft spot on top. And the mastoid is actually kind of right behind the ear that you can use to see the posterior fossa better. And head ultrasound is very good for structural information and also Doppler. So we can use Doppler, basically flow, to look at resistive indices, which are a measure of flow in the blood vessels that may tell us, be indicative of a certain pathology. And so we use it a lot to look for ventriculomegaly, for interventricular hemorrhage in the preemies, like I mentioned. There are some limitations, though, that we have to be cognizant of. It is operator dependent and it's fontanelle dependent. So your fontanelle has to be, wide enough that you get a good view of what you're trying to look for. Ischemia and hemorrhage are both hyperechoic. So it can sometimes be hard to differentiate between the two. The posterior fossa is a little bit trickier to see really good detail, and the cortical surface especially. And I'll show you why, just kind of mechanistically, why we don't see the cortical surface very well with ultrasound. And then it can miss smaller lesions. So just because of the limitations of the type of imaging. So over here, you see that this is the anterior fontanelle where you would place the probe. And so you have all of these different cuts through the brain. Notice you miss a lot of the cortical surface, right? So important to keep in mind. But as you kind of sweep anterior to posterior, here are your two frontal lobes, the interhemispheric fissure comes into view. You have your corpus callosum going across the center, your lateral ventricles, your cavum septum pellucidum, which is normal to be cavum in a baby, your sylvian fissures, your cerebellum pops into view, the choroid plexus, which is the very, again, a very vascular structure. That's why it's so hyperechoic, because it has so much blood. That can trick you into thinking that it is hemorrhage, but in fact it is normal. It's where most of the cerebrospinal fluid is produced. And so that is the view, and then you can kind of turn the probe and look at sagittal images. So you can see the nice view of the corpus callosum. You can get a good sense of how big the ventricles are. You can even see the fourth ventricle, anterior the brainstem, the cerebellum back here. Again, your choroid plexus as you sweep more laterally. And then here again is, so the caudothalamic groove that I talked about where the germinal matrix lives. So this is the head of the caudate. And then this is the thalamus. And so the germinal matrix lives right in there, that caudothalamic groove, and then the choroid extends more posterior. So this is one of the best views to look at for, more subtle interventricular hemorrhage or germinal matrix hemorrhage. And then the mastoid fontanelle is back here, kind of behind the ear, and so we can use that to look at the posterior fossa, which includes the brainstem and the cerebellum. And so you kind of have to turn your head a little bit, the top of the brain, to orient the top of the brain's down here. And then this is your cerebellum. So you can see your cerebellum, your two hemispheres, your fourth ventricle, your third ventricle, and then these are the temporal horns of the lateral ventricles. So you can see, you get a decent view, would be able to pick up on big hemorrhages. So let's take an example of a normal head ultrasound. So this is a normal term head ultrasound. Again, important to know gestational age. The ventricles are pretty small, but that can be normal in term babies. And you can see that choroid plexus jumps out at you as very hyperechoic, but that is normal. And I'll talk a little bit about what IVH looks like and how we can sometimes determine if there is interventricular hemorrhage rather than just choroid plexus. So that's an example of a normal head ultrasound. Like I said, the choroid plexus is echogenic or hyperechoic. So that means it has a lot of blood in it. It's very vascular, so it's very bright. I usually use the choroid as my rule of thumb. Like if something is more hyperintense or hyperechoic than the choroid, it's worrisome that it is pathologic. And then the brainstem's also going to be pretty hyperechoic. The cerebellar vermis in the term baby is pretty hyperechoic. In a preterm, it's going to be less so, but once you hit term, it looks pretty bright. Okay, so I've alluded to interventricular hemorrhage just because it is so common in preterm babies, and that's really a major indication for why we get head ultrasounds in preterm babies is to screen for IVH. So let's talk about the different grades. So grade 1 is a bleed that is confined to the germinal matrix. And the important thing here is that it looks encapsulated, right? So you get this little kind of capsule of blood. Here's some more examples. So that, they can look pretty, quote unquote big, but as long as it is encapsulated, there's no actual blood in the ventricle. That's questionable. That might be a clot, but as long as there's no actual blood in the ventricle, then it would be considered a grade 1. Grade 2 is when you have blood in the germinal matrix, but then it gets into the ventricles, but the ventricles are not dilated. So an example of this would be, so you have blood in the ventricle, right? But you can't tell if it's a grade 1 or grade 2 just based on this. However, you see in the occipital or the kind of dependent layering is often a clue. Like you get this dependent layering of blood at the back of the occipital horn of the lateral ventricles that says, okay, the major bleed was in the germinal matrix, right? But now you have blood in the actual lateral ventricle, so then it becomes a grade 2. Grade 3 is blood in the ventricles with ventricular dilation. And it's important to know that, so we use this grading system based on the worst grade up to day alive 7, because Dr. Moriarty is going to talk a lot more about this, I think, but you can get post-hemorrhagic ventricular dilatation and post-hemorrhagic hydrocephalus after you have bleeding into the ventricular system, but that would not make that a grade 3 unless it happened more proximal to the actual bleed, right? So that's important to know that the official grading is actually in the first week of life, the worst grade. And then what used to be called grade 4, but we're kind of moving towards the term periventricular hemorrhagic infarct, because it's more descriptive of what it actually is, because this is not a bleed in the ventricle that then the blood actually extends and seeps into the cortex. It is a secondary venous infarction. So I'll talk a little bit more about what happens there, but you can see it's actually a venous infarct caused by back pressure, we think, and inability of the vein to drain, and so then the blood has nowhere to go and it bursts. So just a couple stats. IVH, very common in preterm babies for the reasons that I talked about, the fragility of the germinal matrix. 70% of IVH is going to happen by 24 hours of life, and 95% by 7 days. So large majority is going to happen early. It affects as many as a quarter of very low birth weight infants, and 8% of those are severe grade. So we consider the severe grades grade 3 or 4. And then the lower your birth weight, the more at risk you are, of course. So less than 24 weekers, over half are going to have some degree of IVH. So it's a big problem. I already kind of showed you this, so that was a grade 1. More examples of grade 1. Again, some of them look nasty and big, but the important thing is that it is confined to the germinal matrix. Grade 2, look for the clot, the layering of blood in that horn. Grade 3, here is the primary hemorrhage, and the blood is filling the ventricle, and the ventricle is distended, so that is what makes it a grade 3. Here's a quick example, real life example of a 27-weeker who had bilateral grade 3s. So you can see that hyperechoic blood filling and distending the ventricles. Lateral view of it. And then at term, you can see the ventricular dilatation is improved. So not all of these babies are going to go on to develop hydrocephalus or post-hemorrhagic ventricular dilatation. But again, I will leave that to the expert for later. All right. And then here are some examples of grade 4. So here is the concept that we have currently of how this happens. So when you have germinal matrix hemorrhage, it's right here in the caudothalamic groove, you actually have this very intricate venous drainage system of the cortex and subcortical white matter. So you get this kind of fan shape or like tree-like pattern of medullary veins that drain this tissue into a terminal vein that courses right by the germinal matrix. So basically, if you have blood here and you cause enough back pressure into that venous system, arterial blood's still coming in, and it's basically plumbing. So arterial blood comes in, it can't drain out, it has to go somewhere, the pipes burst, and you have a hemorrhagic infarction. And so you can see, you can then develop a porencephalic cyst, is what it's called, once you have that infarction, and it's very, it's kind of that fan shape, so that should be a tip-off. And you can see it's hyperechoic, right? So it's about as hyperechoic as the choroid again, and so that should tip you off that is pathologic. And then you can develop these porencephalic cysts afterwards where the brain dies, essentially. So here's a mastoid view of the fourth ventricle. So I just wanted to point out, you can actually sometimes see a clot in the fourth ventricle after a severe IVH. And if you see this, you better watch real closely for post-hemorrhagic hydro, because once the blood gets into that really small cerebral aqueduct in the fourth ventricle, it's pretty easy to kind of clog up the drainage system. All right, so I've alluded to post-hemorrhagic ventricular dilatation, but it is something that happens after IVH, and from what I was reading, and again, I'll leave this to Dr. Moriarty, but from what I was reading, it seems like there is kind of a complex mix of actual structurally, like physical inhibition of reabsorption of the CSF, kind of toxic and inflammatory mediators. When the blood gets broken down and the hemosiderin lining the ventricles, you just can't reabsorb your CSF well enough, and you produce CSF, you turn it over like 5 times a day, I think. So basically the production of CSF outstrips the reabsorption, and so you get dilatation. And usually it happens relatively quickly after IVH, but that's why we do serial head ultrasounds after a baby has been found to have IVH, in order to pick up on this early and do appropriate interventions as needed, but they can resolve without intervention. So you can see this baby at 4 weeks had some obvious ventricular dilatation with that kind of rounded shape of the ventricle, echogenic ependema there, and then had resolution. So they can resolve on their own. Cerebellar hemorrhage is another common complication of preterm birth. And so this is just an example of what it would look like on head ultrasound. So look at that mastoid window and you can see a hyperechoic circular region. And, depending on which side is up, which mastoid window you look at, it might be on either side. And that was an example of what it looked like at MRI. So resistive indices are very useful in terms of detecting blood flow. So we actually use a Doppler, and usually it's over the MCA, the middle cerebral arteries, to look at the actual mathematical equation is systolic velocity minus diastolic velocity over systolic. So I have to sit and think really hard about, which way. But basically, the RI increases with decreasing diastolic velocities and decreases with increasing diastolic velocities. So a normal RI is 0.6 to 0.8, and it's right here. If you can, see my mouse. So that's stone cold normal, 0.65. It can be either increased or decreased. HIE is probably, so hypoxic ischemic encephalopathy is probably the most common scenario when at least I kind of look at the RI. And it can be increased or decreased depending on the degree and the location. But it will be, if it's abnormal, it would suggest more severe injury. But then things like a PDA, which the diastolic flow is going to be affected. IVH, hydrocephalus, any kind of pressure differentials, or weird flow patterns like produced by an AVM could cause abnormal RI. So just something to be aware of. All right, so MRI. MRI is much more detailed, as you can see. And so I wanted to talk a little bit about how MRI is actually performed, like the physics of it, because it's important, because a lot of the neonatal brain is water, because it hasn't been myelinated yet. And so MRI is basically magnetization. This is my very simplistic understanding of it. Magnetization of protons. So the magnet kind of aligns all the protons, and then it stops the magnetic field and they relax back. And the rate at which they relax back to their resting state depends on the different substrate of the tissue that they're in. So water's going to look different, fat's going to look different, everything in between is going to give off a different signal. But water is important for MRI because if you think about it, water is H2O and hydrogen ions are essentially protons, right? So water, the degree of water in tissue is really important in MRI imaging. So, and MRI is important in terms of myelination. So if you look at T1 images and T2 images, so I'll talk about those on other slides, but I will just say for now that myelination of the axons and the tracts that the nerve cells use to talk to each other, it starts centrally and progresses peripherally, and then it also starts posteriorly and progresses anteriorly. So you can kind of see that progression. Again, it's bright on the T1 images, so that progression to adulthood, and then it's dark on T2 images. And it's essentially complete radiographically by 2.5 years, and I'll talk a little bit more about that in a minute. So myelination starts At about 25 to 28 weeks, parts of the brainstem and a little bit of the cerebellum are myelinated, but that's really about it. So that is why I say babies are brainstems. It's just, most of what is online is the brainstem. And so then by about term age, you start to get the precentral gyrus, which is the motor strip in the cortex, and the corona radiata, which is the white matter that comes from the cortex and kind of creates this fan shape. All of its axons get sent down into the posterior limb of the internal capsule. That's that plic. So the motor system starts to be myelinated around term age. And actually, it gets myelinated a little bit faster in babies who are born preterm, which is interesting. And then at about 3 months, you see the corpus callosum, that big bundle, the central bundle here, starting to become myelinated, because you really can't see it much at term age, see there, or that's even 1 month. So really after 3 months, the corpus callosum gets myelinated. And then again, myelination continues through radiographically through about 2.5 years, but really into your 20s, which is why some of us made the decisions we made in high school and college. It wasn't our fault. All right, so T1 imaging is one of the imaging sequences in MRI where the CSF and water is dark and fat is bright. So if you don't remember anything, that's CSF is dark, fat is bright. And so it's good. You can kind of see the outline of the cortex. So this is a term baby with a normal brain. You can see the outline of the cortex. The white matter is dark because it's not myelinated, so it's mostly water. And then the cortex is a little bit brighter. You can see the beginnings of myelination. So this is the midbrain. So some of the optic radiations also in a little bit of the occipital cortex maybe has started. And then you get the posterior 1/3 of the posterior limb of the internal capsule, very pretty right there. And those are the motor fibers again. So the babies move their limbs, right? And so usually T1 is good for myelination and maturity until about 6 to 8 months. And then afterwards, T2 tends to be better for looking at structure. So look at all that water. It's just very intense, right? A little bit of myelination starting. This is a 28-weeker. A little bit of myelination starting in that midbrain. 32-weeker, still a lot of water. And then, again, the term image with more of the myelination in the brainstem and the plic. And I just thought that was pretty. So this is what I was talking about. Like the motor strip is up here, and then these corona radiata fibers come down and form that posterior limb of the internal capsule. And that's kind of the coronal view of that. More pictures, because I like pictures. So by 6 months, look at how much myelination has happened. So you have your occipital lobes are online, right? The babies are tracking, they're social, they're having some movements of their extremities that are purposeful, right? So they're reaching, they're grabbing. A lot of the motor cortex is pretty well myelinated. You have your whole posterior limb and anterior limb of your internal capsule, so you're getting there. And then by 2 years, this basically shows you complete radiographic myelination. And so the reason that sometimes we say to repeat a brain MRI after 2 years of age is for this reason. So if you don't have myelination, like if your myelination is incomplete, you may not be able to see a cortical abnormality, like a subtle cortical abnormality, because you don't have that contrast between the white matter and the gray matter that you get as the child becomes more myelinated. So here's an example of T2. So it's just the opposite of T1. In T2, water is bright. So I think of H2O, water is bright, T2. And water is bright, and then fat will be dark. So you can see a little bit of the myelination there in the posterior limb, and the internal capsule is dark. Like I said, it's good for overall anatomy and brain structure. Usually after, we look at it a lot in babies, but after like 6-ish months, it's the best. But not as good for cortical differentiation early. More examples, lots of white, lots of water, 27 weeks up to term. So again, an example of just how much happens in that third trimester in terms of brain development. So T2 flare we love in older kids. Flare is basically fluid attenuation, inversion, recovery, something like that. But it cancels out the CSF signal. So the idea is that you can see pathology around the ventricles better. It just makes things easier to see. However, you guessed it, it cancels out most of the water, right? So the baby brain is a lot of water, so it kind of just grays out the brain. So just something to be cognizant of. I'm not going to say never look at it, but it's less helpful in babies, more helpful once you're more fully myelinated. And also in general, it's not good for around the brainstem, because you think about how much water, like water to actual tissue ratio, the brainstem's pretty small and there's a lot of CSF around it. So in general, it's also sometimes washes out things in the brainstem. So SWI or GRE, susceptibility weighted imaging, is another important sequence in MRI in babies because it lets us see blood. So it is based on paramagnetic substances show up dark. So it can be hemosiderin or calcium. So sometimes it's a little tricky to tell, but you can see, oh, something big is there. And so that indicates that it is either blood or calcium. In this case, it's kind of in a vessel distribution, right? And if you look also, you can see kind of a paucity of vessels on that right side. So imaging is also switched, if I didn't say that. So this is the left, this is the right side of the brain. So look at that paucity of vessels. This was a 17-day-old with HSV meningoencephalitis, and she had her right hemisphere was much more affected than her left. And so that paucity of vessels is indicative of that whole hemisphere was basically swollen. So you can't really see the veins because SWI is mostly deoxyhemoglobin, so you can see the veins stand out pretty well. Like you can see all these veins on this side. And then we think that this was probably because of the venous back pressure, may have been a little thrombosis or potentially like just a developmental anomaly. But in any case, we weren't going to anticoagulate this baby because of the bad infection. Blooming is a term that we use in SWI that refers to basically the lesions are magnified. So it's not actually as big as it looks, but that makes it good for finding kind of microhemorrhages and very small things. It will make the hypo-intense areas look bigger than they are. Diffusion imaging, love on MRI. This is the best imaging to look for acute injury, basically. So acute infarct. This is an example of, so this is a DWI image, diffusion weighted imaging. And this is ADC, apparent diffusion coefficient. You use the two together. The DWI is the actual source image, and then they do some math or something and make the ADC. But whatever shows up bright on DWI and dark on ADC is acute. So I shouldn't say that it's always cytotoxic edema, but a lot of times it's cytotoxic edema. So basically, what diffusion restriction is referring to is that the water molecules can't move. And so whatever is restricting diffusion, so it can actually be like an abscess, a pus-filled fluid pocket. Sometimes clots can restrict diffusion. Like if you have a cerebral sinovenous thrombosis, it can restrict diffusion. So anything where the water is not moving, the ion channels are disrupted, the ATP pumps aren't working, and the cells are dying, you think about diffusion restriction. So this was a good example of a left MCA stroke in a baby. So you can see all of that is tissue at risk for dying. Doesn't necessarily say that it will definitely die, because you can get diffusion restriction from seizures, from cytotoxic edema from seizures. And so just to go along with this same case, this is the SWI imaging, right? So you can see that paucity again of blood vessels on that side because of all the edema, whereas you see all of his veins on that other side. This is T2, water's bright. So T2, the changes after acute injury are going to take a little bit longer to show up, but you can see, I mean, that's all the increased water content, right, and the edema is making that brighter. It blurs out the gray-white matter junction. And here's T1. Again, edema, water, graying out, or, blurring of the normal brain structure. 2 weeks later, what happens after an injury like this is you undergo encephalomalacia. I told you flare isn't good in babies, and here I am showing you one. So I said sometimes, just take into account. But in this case, the encephalomalacia is basically the brain has died and been replaced by CSF. And so you can see that well in this image. So encephalomalacia usually starts to happen around like 10 days to a week and a half after an injury. And then, so this was a diffusion weighted image, again, after 2 weeks of injury. And I made a point to, so something doesn't look like the last diffusion image on that DWI, right? It doesn't look bright. That's because sometimes you got to keep scrolling. So you want to scroll through to the B1000. And then you will get a nice view. So you can see there is still diffusion restricting. Look, the internal capsule's diffusion restricting. This is actually, it's not a new injury. It's actually Wallerian degeneration. So those axons are dying all the way down through the brainstem. All right, quick word on CT. So we don't use CTs in babies a lot. However, I did recommend one on Wednesday, so you never say never again. But it is, it's good for bone, definitely superior for bone. It's good for acute blood, and for looking at midline shift, anything that's urgent. So like abusive head trauma, rule out, stuff like that. Neurosurgical considerations, or when head ultrasound or MRI is not feasible or available, but you just have to be cognizant of the limitation. So this is a normal head CT in a term baby. It's pretty black. So if this was a several-year-old child, you would say, oh dear, diffuse cerebral edema. So again, got to know the age, but the reason why CTs aren't as helpful in babies is just because of the very high water content. So just be aware of that. But it is good for kind of acute emergent situations. In terms of the radiation, so we always worry about radiation with CTs, but the actual data. So there is a 3-fold increase risk in brain cancer after 3 head CTs. However, so that sounds bad. The absolute risk is still small, 1 in 1,000. So, moral of the story, get the head CT if you need it and if it's going to change management. But if you're going to CT a baby daily for weeks, that's probably not a good idea. So just use your best judgment. It is, so a CT we will sometimes get if we can't really tell on SWI imaging if something is calcium versus blood, like if we're ruling out a torch infection. Head CT is often better for calcium because you can tell based on the Hounsfield units, of this bone, if there are little punctate things in the brain. It can sometimes be helpful for differentiating that. All right, one more example. Uh-oh. Guys, I can't remember what I was showing you with this. Sorry. Anybody, anything jump out at you? Huh? Okay, well, we'll just go on. So see, it's hard to tell pathology on head CT, right? Moral of the story. Now I know. Because this was the MRI of the kid. Okay, so initially this was read as normal. as I just thought. But look at that hypodense region in the anterior temporal lobe right there. Is that abnormal? It's hard to tell on CT. And then on this axial view, you wouldn't really, so this was a 4-week-old who came in with apnea and kind of like just behaving poorly. Can't really tell that there's a subdural until you look at the coronal, which you can't see. It's underneath here, which is a shame. But trust me, you can see like a very thin hyperdensity. Shoot, I'm sorry you can't see the coronal. But this was what showed up on SWI, so blood. See that? Blood, IVH, subdural hemorrhages. Subdural hemorrhages right there in the posterior, all along the falx. And then diffusion restriction along those areas. So that anterior temporal region, look, was diffusion restricting. You have some frontal lobe injury. So the limitations of head CT, but you got to look closely sometimes for hypodensities that could indicate pathology, and then for subtle subdurals. All right, so those are my references, and sorry for talking so much, but anybody have any questions?